Assalamu alaikum everyone and good afternoon. Thank you all for joining us today for our second webinar, The Poison Hour by Isam. Today we have, we have Dr. Samia Ghennai, who is a PharmD specialized in toxicology. She holds a diploma in applied statistic to medicine and clinical research, and she has published several scientific papers related to toxicology and clinical toxicology. She is currently the senior poison specialist at the Poison and Drug Information Service at DOH. Samia as well, before joining DOH, she used to work at the National Poison Center in Algeria, where actually she completed her formal training in toxicology. Welcome, Dr. Samia. Before we start,
Thank you so much, Dr. Afra.
Sure. I'm sure the topics will be great today, something that we really encounter all the time in the emergency department. I just want to, add that for those who would like to share their thoughts, your comment, please use the question and answer chat, as we don't have a regular chat in this webinar. But you can utilize it. You can put your questions and we would answer them directly. So we'll start with our presentation and we will keep the last 15 to 20 minutes for discussion and question. Go ahead, Dr. Samia.
Thank you. Welcome, everyone. Thank you for joining us today. We'll be discussing this critical topic, the management of acute overdoses from drugs of abuse. This topic is particularly relevant for you as frontline clinicians, and our goal is to equip you with practical and evidence-based strategies to improve patient outcomes. I declare no conflicts of interest related to this talk. Let me just move. I would like to start before going to specific substances. Let's remember the fundamental role of toxicology and emergency medicine, the ABCs first. Always, no matter what you suspect the poison is, your first priority is to manage the airways, ensure adequate breathing and oxygenation, to ensure or to support circulation. The antidotes and specific therapies only come after the patient is stabilized. After the ABCs, your most powerful diagnostic tool are your hands, eyes, ears. So be detective for the clinical evaluation. Search for example, fentanyl patches under clothes, needle marks, etc. The history. So if we consider resuscitation is what we do first, risk assessment and history is what we think first. So this is the brain work for toxicology. Every piece of information here in this slide is critical. The patient may not be able to give you a reliable history, so talk to everyone involved, get your hands on any evidence from the scene, call them, go back to home, see there, especially if the patient is unconscious. Try to establish the 5 Ws here of the exposure. This step determines everything that follows. How closely we monitor, we extend time if we have extended release drug, what test to order, and where the patient ultimately goes. This is really important. Type of questions, what's the quantity, any name, any photo, any related information regarding the patient, to do our risk assessment and estimate the outcome for this patient and what we need to do. Here in this slide, you can see I'm sharing the forms and the different routes of exposure for drugs of abuse. You can see the blotter paper. Maybe you are already aware about it. Blotter paper is a highly absorbent paper that serves as medium for distributing the potent psychodysliptic. We will see it later, a drug like such as the LSD. This paper is soaked in a liquid solution of drug and then will be used orally or sublingual, and then they will use it like to have the high with these drugs. In some countries, it's mainly for used by the teenagers. Regarding the GI decontamination, we have two methods. The first one, for the activated charcoal, it's effective only with the within the golden hour. Other exceptions are the body packers, for example. But the thing is, the patients with drugs of abuse, mainly they arrive late. The drug is already absorbed, or it wasn't even taken orally, as we saw in the previous slide. Also given charcoal to patients with depressed level of consciousness or other symptoms like vomiting is very risky, with the risk, as you know, the risk of aspiration. On the other hand, the whole bowel irrigation, it's indicated mainly for the body packers. We need to get rid of that from the guts, to get it out using the POG solution. And mainly it's for the body packers that they use multiple well-wrapped packets, not for the stuffers, mainly because for the stuffers we will increase the risk of breaking this packets. The challenge that we face, or that add another layer of complexity in managing these cases, is the polysubstance use. So we are no longer treating clean overdoses. Patients are frequently taking a combinations of drugs, which can create confusion clinical pictures and make our job much harder. Let's start with our first case. This is a tragic example of polysubstance overdose. This male with known substance use history, he was found in deep coma, GCS3, with constricted pupils and shallow respirations. Uh, it's a textbook opioid toxidrome. Pre-hospitally, he was also hypoglycemic. After receiving dextrose and total 5.2 milligram of IV naloxone, he had a remarkable recovery and was alert upon arrival to the ED. In the ED, his vitals showed tachycardia and tachypnea, which he attributed to heroin use alone. However, the urine tox screen showed um, like told a different story, returning positive for both opiates and cocaine. We all so we all know the triad for the opioids, but before going that, we consider here the pathophysiology of opioids. To understand that, so we will understand like why these patients die. Opioids are powerful inhibitors. At the cellular level, they hyperpolarize the neurons, making them less likely to fire. So the critical area here is where all this happen, in the brain stems respiratory control centers. Essentially, the brain stops responding to the normal signals to breathe, high CO2 and low O2. So this is why ventilatory support is the cornerstone of the management, not only the naloxone. So the triad, we know about this triad of opioid toxicity. However, with the dominance of fentanyl and its analogs, we are seeing more dangerous and atypical presentations. The most significant change is the speed. So patients can stop breathing almost instantly after use, often before EMS can arrive to them. You also need to be aware of unique features like wooden chest syndrome. This is like very this requires sedation to overcome for these patients. Also, some cases we can find the seizures, but the meiosis here, for some of opioids, the meiosis is not there. So this is can cause us, they can mislead our diagnosis. The meiosis is not always present. Sometimes we have also co-ingestion of sympathomimetics. This can cause a normal or dilated pupils. So always we prioritize the respiratory status over the pupil exam. For the management, generally, the first step is to manage, is to breathe for the patient. So we use the back valve mask while we prepare naloxone. So for the patient in full arrest, we give full dose of 0.4 to 2 milligram, and we repeat as needed. Don't be afraid to give more. You can't kill someone with naloxone, but you can if you don't give enough. However, if you know or suspect the patient is opioid dependent, we start with a very small dose with 0.04 milligram or 0.04, and we titrate up every few minutes. This is just to prevent precipitating violent and dangerous withdrawal. And the goal here is to get them breathing adequately, not to have them wide awake and agitated. So for if we have, for the long-acting agents, if we have only the respiration restored, we can use the continuous infusion with a 2/3 dose of the initial of the total dose effective of naloxone. Going back to our case, so the patient was observed in the ED for just 5 hours and was deemed stable. So they didn't note any decreased in breath sounds or any potential sign of pulmonary edema, but this based on this recovery or this apparent recovery, he was discharged. Tragically, about 5 hours later, he was found in asystole and could not be resuscitated. Post-mortem exam revealed multi-organ congestion, and they confirmed the recent cocaine use via the metabolite benzoyl egonin. This case is a classic tragic example of the naloxone and release paradigm. Why? Because the decision to discharge was flawed because the patient's apparent stability was a toxicological illusion. So one of the lessons for the naloxone is to extend the observation period, especially if we have polysubstances use, we need to admit the patient and continue the observation. So the most point here important is naloxone half-life, which is very short compared to any of other opioids, especially the morphine as a metabolite. This patient needs the 6 hours, but in case of polysubstance use, we need to admit, as I said, and discharging them too early is potentially fatal error. For our case, for example, as you see, the stimulant effect of cocaine masked the potential for recurrent respiratory depression from the longer acting morphine, which is the active metabolite of heroin, as I said. And this is arriving to this question. We appreciate your responses with true or false.
You can utilize the chat or the answer and the question to share your thought.
Patient is brought in after suspected overdose of heroin. They repeated naloxone, but the patient still in respiratory distress.
So we have here to answer false. What about the rest? What do you think about this statement? Good. We have also false. It doesn't rule out. Okay. We have false. Okay.
Oh, okay. Thank you.
Okay.
We can
We can
continue. We
proceed.
have other questions also. So the correct answer is false, as we saw in the as we will see in the other cases or in other cases for naloxone. But I think I didn't mention carfentanil. Yeah, because carfentanil is one of the potent opioids. It's very potent, and if they purchase heroin and they are not sure about it, maybe it's a dose of maybe it's carfentanil or other derivative, and these ultra potent opioids need a huge amount of naloxone to be reversed. Some of them 10 milligram. So this is the issue here. So for this clinical scenario, the failure of naloxone should not rule out the opioid, and we should strongly suggest the involvement of this potent analog, and we need to administer high and repeated dose of naloxone and potentially continuous infusion after that to overcome the potent antagonist effect. I have another question here. Young adult with known polysubstance use history presents to the ED after an overdose of tramadol. The primary and most life-threatening complication is the respiratory depression. Is it true or false?
I'm not sure if this answers just came now, but we have here uh, someone saying it's false. Okay,
Yeah,
false.
false. Okay.
Could be, but seizure can happen as well. We have also another
Could be
answer,
seizure.
false.
Okay, false. The correct answer is false. Um, why? Because for tramadol toxicity, unlike classic opioids, where respiratory depression is the primary concern, uh, for the tramadol, as one of the attendees said, it's actually seizure. This unique feature is due to dual mechanism of tramadol, dual mechanism of action, which includes inhibition of serotonin and norepi reuptake in addition to its weak opioid effects. So that's why the high risk is seizure more than the respiratory depression, especially in young adult populations when they are who they are misusing it. So this is for the tramadol, just a quick overview about tramadol. So we be aware like about this risk for the seizure should be treated with benzos. This is for the treatment, and um, this like tramadol is a little bit complex because we may have many effects, not only these mentioned here in the slide. This is another question. A patient presents to the ED from a party with severe symptomatic toxidrome, including extreme agitation and temperature 41 after ingesting a substance believed to be bath salt. What is the cornerstone of management for this life-threatening condition?
Since there is like multiple choice, I think you can just like say A or B or C or D. What do you
Yeah,
think?
A, B, C, D. However, I will not give you the answer here. We will go directly to the slides for
So
stimulants.
we have different
Yeah.
answers actually, Samia. We have
Okay.
someone
Yeah.
saying supportive treatment A, B, C, and for rhabdo and which it is B. And
Okay.
then I think we have another
C.
saying
Gastric lavage. Okay.
yes.
Yeah. Okay.
We have B as well. Another
Yeah.
one saying B.
Okay. B is as a response to,
Yes.
yeah, they changed it C to B. Okay. Okay, let's go just to the next slide. We'll have the response directly when we go through stimulants, mechanism of action, and management. So here, I want to just about B to say something here about gastric lavage. If you want to say something about it, Afra, gastric lavage.
So gastric lavage usually is not recommended anymore. Gastric lavage considered a very like aggressive, or invasive procedure that not anymore recommended. It used, most of a practice, which is this practice noticed mostly in the Middle East, that where people will insert NG tube and then they will flush the NG tube with some saline and then aspirate it back. But basically, this is not gastric lavage. This is called NG tube aspiration, which is something not recommended, not even there outside in literature or in any like textbook, toxicology textbook. The NG tube, which is very, very common in the region of the Middle East. So gastric lavage usually it's a huge, large tube. It has two bore that basically inserted through the mouth because it is really huge. And at that point, patient should have a protected airway. And basically, one tube will be used or one pore will be used to flush like saline, which at least should be 500 cc to flush it, and then re-aspirate it again. However, it is not any more recommended and it didn't show any benefit. It does not decrease the toxicity, but actually put the patient at risk of more other complication. Yeah.
Thank you, Afra. Thank you so much. Let's go. So I agree about that. That's why in the first slides I mentioned only two decontaminations methods: the whole bowel irrigation and the activated charcoal. That they are not used for every case you receive for drugs of abuse, but as I mentioned, the limitations and the indication in that slide. For the stimulants. We are considering the cocaine, amphetamine, methamphetamine, other synthetic cathinones, the captagon, which is the phenethylline, which is amphetamine plus the theophylline combined in one molecule, which is phenethylline. Its use is very common here in the region, in Syria and the Middle East. And the huge amounts are seized every year, and there is like many like programs to get rid of this problem, local problem. For the mechanism, we are in the opposite end of the spectrum. Compared with the opioids, or we have here, we are as the epidemiology shows here in the region, the stimulants are a major and growing problem here, whether it's cocaine or meth, and the final common pathway with these stimulants is the massive adrenergic storm. The synapses are flooded with norepinephrine and dopamine. This leads to profound alpha and beta stimulation. These patients are agitated, hypertensive, tachycardic, and hot. Everything is overdrive. So for the toxidrome, the complications are severe and can affect nearly every organ system. But the ones that will kill the patient the fastest are the cardiovascular collapse, seizures, and especially the hyperthermia, which is a strong predictor of mortality. So it's helpful in general, it's helpful to know the difference between drugs. If we have cocaine, it's fast on, fast off, with risk of cardiac arrhythmias because it has like sodium channel blocking properties. If we have methamphetamine, it's different. It lasts for hours and may cause severe and prolonged psychosis. If we have bath salts, it can be the most dangerous with extreme and unpredictable behavioral effects. This is mainly for the presentation, but for the management, the first line is benzos. If supportive care is the cornerstone for toxicology, the benzos are the cornerstone for these stimulants. So this is the single most important treatment if we consider like because we don't have a specific antidote. This is very, very important. They are like we cannot say antidote, but it will help with adrenergic storm. They work centrally to calm the agitation, to bring down the heart rate, blood pressure, temperature. So we must be aggressive. For these patients, they need the sedating effects of benzos, and we need to escalate the doses until like we give them until they are calm. Um, the second thing, very, very important, is to manage the hyperthermia. This should be immediate and aggressive. The patient, we have to cool them from the outside in use of from the outside in. We need to use the measures that you have in the ED. No need for paracetamol; it will not work. The most important treatment, which is the benzos, will help with that, but we need also to do the external cooling. For the hypertension, it will usually respond to sedation, but if it doesn't, we need to reach for direct vasodilatator. For rhabdomyolysis, we need to do the treatment, which is the aggressive fluid resuscitation to protect the kidneys. This is mainly the management for the stimulants. Another case here we have, this case demonstrates the toxicity of so-called party drug. This 21 years old female, she consumed a single tablet of ecstasy. Hours later, she was found at home, responsive and cyanotic. On arrival to the hospital, she was in deep coma, requiring immediate intubation and vasopressor, with dopamine before being transferred to the ICU. Her admission labs showed severe hyponatremia with sodium of 126 and elevated CK, consistent with rhabdomyolysis. They did the care, and she was declared brain dead 2 days later. The autopsy confirmed the cause of death was massive cerebral edema and brainstem herniation. This is like direct result of the acute hyponatremia. The post-mortem toxicology confirmed the MDMA, which is the ecstasy. And this case show us the complex metabolic derangement that can happen, specifically here the SIADH and the delusional hyponatremia, and that can make even a single dose of ecstasy lethal. So this is so important due to within the investigation that we should do with the suspected drugs of abuse overdose. We need to have our panel and be detective and see if we have any hyponatremia, which is a very life-threatening condition. I have here a question. A patient presents with a classic symptomatic toxidrome and severe agitation delirium, and we had negative urine drug screen or immunoassay for amphetamine and cocaine. Um, is this rule out any stimulant use? True or false?
We have here answer false. Urine
False.
doesn't detect all the type of metabolites. Okay, excellent. We have false. Most of the answers are false.
Yeah. Actually, it is false. The point is not only the metabolites, but even the molecule itself. For example, the tramadol, if we mention tramadol, because we are not about tramadol here are with the stimulants, but in general, um, many substances are not included in the urine drug screen. Urine drug screen uh, is are families. For example, opioids family are families, amphetamines family, but benzos family, but not all the substances available are included in this test. So here uh, we cannot rule out, and it's like a rule-in test for a very limited panel of substances. This is the truth. And the patients can be severely intoxicated with any different drug. And if we use this diagnosis, we um, will not like treat the patient as we should. So here we should treat a negative urine drug screen as a non-contributory piece of data rather than an evidence. Now let's go to the synthetic cathinones or bath salts, because they can produce one of the most dangerous presentation in toxicology, which is the excited delirium. This is a state of extreme metabolic chaos. These patients are hot, acidotic, and at imminent risk of cardiac arrest. Your single most important here is to gain control of their extreme agitation with rapid and profound sedation, which almost always means very large doses of benzos. We have this question here. The primary toxicological threat of benzos and the most common reason they are implicated um, in fatal overdoses is their tendency to cause fatal cardiorespiratory arrest when taken in overdose by themselves. True or false?
So we have most of the answers saying true. Samia, you can proceed. True. Most of the answers goes with true.
Okay, so the correct answer here is false. Why? Because pure benzodiazepine overdoses are rarely fatal. Their primary danger lies in their role as force multiplier in multi-substance poisonings. So they act synergetically with other CNS depressants like alcohol, opioids, to cause profound and often fatal respiratory depression. So the safety of benzos when they are used alone or in pure overdoses, we don't have this risk. This is why the combination of benzos, opioid, alcohol, all this, all other substances are considered as lethal cocktails. Mainly the sedative hypnotics here, I'm considering mainly the benzos. Also the Z drugs like zolpidem are with um, similar properties. So these substances enhance GABA, um, our brain's primary off switch, and a key point to remember here um, is like we it's unlikely to have death with only this pure isolated overdose. And the patients, what we remember are patients with benzos are may appear comatose with normal vital signs. This is the main presentation. If you see a sedated patient who is also hypotensive or bradycardic or apneic, you should be looking for co-angestant, alcohol, opioids, or others. The treatment for benzos in general is simple and effective. Good supportive care. Just IV fluids, just observe the patient and wait until the symptoms will resolve, and that's it. Flumazenil. Flumazenil, I want to spend a moment on flumazenil because it's not an antidote we have, but one um, we should like rarely, if ever, use in overdose patients. Why? Because it's dangerous. If your patient is a chronic benzodiazepine user, flumazenil will throw them into severe withdrawal. This is one thing. Other thing, if you've co-ingested something like tricyclic TCA, tricyclic antidepressant, flumazenil can mask that drug's lethal effects, and the risk will be like the seizure threshold will be lowered, and we will have that effects when we use flumazenil. So its use is restricted to very specific controlled situations with really naive patients, benzos naive patients, iatrogenic medication error, for example. And the most important point I wanted to highlight here is the flumazenil is having short half-life, 2 hours compared to less than 2 hours compared to all the benzos. And also, there is no indication of flumazenil if intubation was done. After intubation, there is no need to give flumazenil. So good and basic supportive care is the much safer path for benzos. We finished with opioids, stimulants, sedatives, and now we arrive to another category. We will see the cannabinoids and also hallucinogen. Cannabinoids, it's critical to distinguish between cannabis and synthetic cannabinoids. They are not the same. THC is a partial agonist and typically cause mild self-limiting toxidrome, but synthetic cannabinoids or spice, example, are full agonists and are far more dangerous. They can produce life-threatening symptomatic crisis that looks identical to a severe amphetamine overdose with extra effects. And remember, your drug screen will be negative. So this is a purely clinical diagnosis for the synthetic cannabinoids. Um, regarding the management, it's um, regarding the management, it's all about supportive care, quiet room, reassurance, and maybe small dose of benzos for anxiety. But this is for the natural or for THC. But for the synthetic cannabinoids, you must shift your mindset completely and manage them as you would severe amphetamine overdose. This means aggressive use of benzos, IV fluids, active cooling, and the clinical care peril here, or what do you need to think about is spice when um, about spice is when you see a patient who looks like they have a raging amphetamine overdose, but the drug screen comes back clean. At this point, you may think about spice, especially if you have extra weird effects or different effects than the amphetamines. Arriving to like hallucination, arriving to other hallucinogens, we can mention here two categories, the classic ones and dissociative ones. The classic ones are generally physiologically safe. The danger comes from the patient's altered perception of reality. The best medicine here is not pharmacologic. It's a calm environment. It's reassurance also. But for the ketamine and other dissociative substances, we should look for nystagmus in our exam. These patients can be very agitated and they are at high risk for rhabdomyolysis. So management focuses on sedation with benzos and protecting the kidneys with IV fluids. This is mainly for the hallucinogens. Our final case involves an overdose on designer benzodiazepine. You will see just later what is the designer benzodiazepine. Um, as you see, the name here is a little bit different than that we use, is clonazepam. The 31-year-old male here with history of depression and alcohol abuse, he took this liquid of clonazepam. He was found about 30 minutes later, confused and somnolent, and on arrival, he was like his airway with borderline oxygen saturation, and uh, we this is like mainly for the AD presentation, as you see in the slide. Um, we will go back to this case just after these two slides. What are the MPS? MPS are the new or the novel psychoactive substances or the new psychoactive substances. They represent a constantly moving target. They are designer drugs that are continually being tweaked in labs to stay ahead of the law. This means we often have no idea what their exact effects will be, and they won't show up on our standard drug screens, and the products themselves are inconsistent and often contaminated. This makes diagnosis and management extremely difficult. Because of this uncertainty, we must fall back on our core principles. We treat the symptoms in front of us. We use the toxidrome approach to guide our supportive care. Let's look at two examples of this MPS. The spice K2 are not marijuana, they are MPS. They are powerful, full agonists, and also um, um, they are also like causing the extreme psychosis and seizures. And also we can mention some outbreaks happened with these products where they were contaminated with superwarfarin, rat poison, leading to patients bleeding to death days later. And we also can consider the other benzos as we have in the case, and also like etizolam. These are incredibly potent and are a major contributor of overdose death, often in combination with opioids. The contaminant, highlights the unpredictable danger of MPS. So you are not only dealing with the intended drug, but also any number of unknown and potentially lethal contaminants. They produce this MPS in clandestine laboratories with no conditions, good condition for manufacturing, nothing, no controls. So they mix anything. You can find even paracetamol in those products. That's why paracetamol is mainly we do it for any overdose or a known exposure. So we check if we have any paracetamol if paracetamol was also taken in that I mean in the during the overdose. Returning to our case, the labs here were significant for elevated alcohol of 204, and it was also positive for cocaine. About 90 minutes after he ingested the clonazepam, his condition deteriorated and he developed respiratory depression. Given the history, and they decided to give the flumazenil, and he responded immediately with a small dose, and he required the second 1 hour later, but he was doing well later after that. So here you can see for this drugs MPS, the management also the toxicologists are not aware about all the MPS. They are not aware about how to treat and what's the clinical presentation will be with these substances. Mainly, we use the case reports. Now, for one thing you should avoid is to not trust the urine drug screen. It is deeply flawed test. It missed fentanyl, it missed bath salt, it has false positives and false negatives during because of the cross reactivity. So the confirmatory tests are for sure give us more idea, but they are not available in every hospital. And these tests never be used to rule in or rule out a diagnosis. We treat the patient in front of us. Um, we do not treat the urine drug screen. For example, we don't give naloxone to a patient who is awake and breathing fine just because we have a positive drug screen for opioids. This is generally the information about urine drug screen. And arriving to the end, polysubstance use and designer drugs mean that the need patterns we learn often don't apply anymore. You have to be prepared for the classic toxidrome model to fail you. When you can't recognize the pattern, what's left? The fundamentals. A rigorous physiology based approach, the clinical examination, symptomatic treatment using the general tool for drugs of abuse, poisoning management, and your mastery of supportive care is the ultimate safety net. Thank you so much for your attention, and I'd like to open it up for questions now.
Thank you so much, Samia, for this great presentation. Thank you. Please, for those who want, to ask question, and if you feel it is easier, to speak, I can unmute you at any time. Maybe you can just raise your hand, and I will unmute you so you can ask your question. And also, of course, you can utilize the question and answer bar. Any question? Okay, so we have here a question. Activated charcoal use. How to convince patient to take the full dose? Samia, do you want to answer this question?
The activated charcoal use. So
Activated
the
charcoal.
yeah, the patient, actually, this is tricky, so tricky when you receive a patient because with drug of abuse use, so it depends on the status of the patient. He came like confused, or if sedated, or like not fully awake, this is contraindicated. If vomiting, not contraindicated. But if all is good, within 1 hour, so this is rare to happen that the patients come in within 1 hour after that. Um, if he's like he wants the treatment and having like like symptoms, like he's suffering of symptoms like hypertension or something, the point is to what we will use to convince is our usual like methods, like to you will feel better, you will get rid from this drug, or especially sometimes we don't know even if he took or no, but we know that what he took exactly, but 1 hour before. So at this time we will use our methods to convince, for example, to give the argument. This is like general question, to give the argument of you will feel better after that. This is the taste is not very good, but you will feel better with when you use it. We use our regular things to convince.
Okay, great, Samia. I would say I will add one more thing. What I think you can do is you can mix it. You can mix the charcoal with juice and then give it to them because it does not actually make it less effective. And still you can do that. And this is especially can be used in pediatric because I think adults you can convince them easier than pediatric population.
Yeah, in
That
pediatric
answer.
we mix with chocolate. Yeah,
But I think milk chocolate or juice,
yeah.
yes.
Mainly we
What?
give milk chocolate, and they can accept it. For adult, generally
Any
it's
other question?
yeah, they can take it.
So I will just like pause for a few seconds before we can, wrap up our webinar of today. I'm just gonna like wait for like a couple of seconds to see if there's any question. Okay, we have somebody who want to share with us. Good. Yes, Sayed and Rabi.
Yeah, hello. Can you hear me?
Yes, we can hear you.
Yeah, I have a question about do you guys have tox kits available for EDs? Like anybody who comes with any sort of poisoning, we have a tox kit available.
Tox
So,
kit, usually we don't have a tox kit, but we have like the antidote room where basically
mm,
we store most of the antidote that required. Of course, like here in the OH, there is a guideline and a policy that should be followed by most of the hospital in the region or in the Emirate of Abu Dhabi. Basically, there is like, I mean, a specific antidote that should be available in each hospital. I think Samia can maybe elaborate more about this.
okay.
Yes, here in Abu Dhabi, we have the standard of antidote stocking, mandating having a minimum stock of antidotes. There is a basic list um, and the advanced list. Basic list, we should have it in all the hospitals with urgent care, and the advanced list we should have it in all hospitals with emergency department. Um, uh, in the hospital. So this is a standard. It is available online. Just you can Google it. Department of Health antidote stocking standard in healthcare facilities. You will find it, and there is a list. So the basic list is too short, and we have advanced, which is more contains more antidotes, and this help us to ensure that um, for the poisoning cases, we ensure that the antidote will be available for poisoning cases received in our hospitals in Abu Dhabi.
Okay, because I am practicing in Dubai, so I don't know about Dubai. So I will check it. Thank you. Thanks a lot.
Thank you.
You're
Thank you,
most
Sam.
welcome.
Yes, thank you, Sami, for this great presentation. I think we are going to wrap up of today webinar. Would like to see you in our next webinar, which actually will be on the 30th of October, 12 p.m. Dubai timing. Thank you all, and see you next webinar, inshallah.